Hello, everyone, and welcome to Lecture 2 in our 4-part lecture series on mental health and aging in rural areas. My name is Morgan Stengel, and I am a second-year PhD student at the School of Social Work here at the University of Iowa, and I am working with Dr. Nadia Saba-Steinberg on this lecture series. In our previous lecture, it was just briefly on the overview of mental health for older adults living in rural areas. And in this lecture series, we will be having a more specific discussion on older adults and depression and suicide. We'll also be discussing primary care providers and mental health. And primary care providers can be abbreviated as PCPs, which you will see in this lecture series. We'll also be talking about stigma as a barrier to accessing mental health care and the ways that we can overcome stigma and help older adults access mental health care services if they need it. We'll also be bringing in one part of the 4Ms, medication. The 4Ms is a framework designed by the Institute for Healthcare Improvement, and it is an essential set of evidence-based practices. And it works to align healthcare providers to what matters to older adults and to their family and other caregivers through 4 different areas, which is what matters, medication, mentation, and mobility. In the last lecture, we talked about what matters to older adults and their values in their mental health care. And in this lecture, we'll be briefly going over medication in terms of mental health for older adults living in rural areas. So let's get started. First, I wanted to give an overview on what depression and suicide looks like for older adults. This graphic here is from the CDC, and it has the female side on the left, male side on the right, that suicide rates for older adults 65 plus is about 31 per 100,000. And 55 to 64 is still high with about 29. So as you can see, there is a serious issue with older adults when they encounter depression and suicide. Older white men also have a suicide rate almost 6 times that of the general population. And this data shows that older adults are vulnerable to the occurrence of depression and suicide. Older individuals are particularly vulnerable to a variety of health problems, ranging from mental and neurocognitive disorders, social isolation, feelings of disconnectedness, as well as the loss of loved ones. And other health conditions can include chronic illnesses and physical pain. And this chart here, also from the CDC, is also showing a higher rate of suicides for males compared to females as they age. So suicide rates in men over age 70 are higher than any other demographic group worldwide. And though it is well established that older men are at the highest risk of suicide, this would not be well known through looking at official suicide prevention efforts. Most of the funding for suicide prevention programs in the U.S., they are targeted to youth suicide prevention. But there is a great need for suicide prevention in older adults. However, there is some important things to also know about depression and suicide for older adults. Older adults are typically less likely than their younger counterparts to suffer from anxiety disorders, depression, and many other psychiatric disorders. And they also typically display more positivity and report higher levels of well-being in research. And although it is true that physical health generally declines with age, the vast majority of older adults do not become suicidal when their health declines. Physical health problems are often a part of the picture when an older man dies by suicide. But the types of illnesses might not be what you think. They may not all be terminal or painful conditions. This can actually include incontinence, poor vision, and hearing problems. Those are more likely factors for an older adult when encountering depression and suicide. Cancer is also a big risk factor for suicides in late life, but research suggests that much of the risk is seen at the onset of the disease. So now that we've talked about overall the suicide rates of older adults and depression, research has looked into protective factors for older adults when encountering depression and suicide. And this can include psychiatric illnesses, personality and coping style, physical illnesses, social stressors and supports, and functional impairments. Research findings also indicate that primary care and other community-based health and human service settings are best suited to intervention and implementation based on these risk and protective factors. Late life suicide preventive interventions can be categorized as 3 different ways: indicated, which targets high-risk individuals; selective, for individuals or groups with more distal risk factors; or universal, which is targeting a population. Relatively few studies of preventative interventions that specifically target suicidal ideation, attempts, or completed suicide have been conducted in this age group of older adults and older adults in rural areas. Current findings have suggested that rates of suicidal ideation and behavior may be reduced by a variety of approaches. However, older women have been more responsive overall to preventive interventions than older men, which is the group at the highest risk. Therefore, challenges remain to reducing suicide-related morbidity and mortality in later life. And when we're talking about older adults living in rural areas, this also is even more difficult to find research on. So how can we bridge the gap between mental health care and mental illness for older adults? And this graphic here I found was interesting because it specifically talked about depression in older adults. So depression is never a normal part of aging. And if clinicians recognize depression, they may undertreat it with low doses of drugs. It can even be confused with dementia at times as well. Therefore, diagnosis rates can be difficult to find. So now we'll be talking about primary care providers. In the previous lecture, we had talked about how primary care providers and older adults have a strong relationship with each other. Older adults trust their primary care providers. So this can be an interesting way to bridge the gap with mental health illness, mental health concerns, to mental health care. So this chart here is from a study conducted by researchers looking into primary care providers and how they can provide mental health care to their patients. So the part that I wanted to emphasize here with percentage of patients that are older than 60. And you can see participants here are all primary care providers. They all have varying years in practice, and they all have small town, rural, or suburban practices. So this part here is trying to look at how can primary care providers provide information to their patients who are older than 60. Results of this study found that depression was common for these primary care providers' patients, and there was a lack of available specialty psychiatric care in these areas they were living in. So the PCPs in this study had to do more learning than they might have otherwise about mental health care, depression, mental health concerns than they otherwise might have known to do in other types of situations. All of the PCPs in this study encountered suicidal ideation, and they had said that they knew enough what to do if their patient had become suicidal, although they would have to cease managing care on their own if their patient was suicidal and refer to any available service. And that could include emergency departments, psychiatric hospitals, and psychiatric specialists, depending on what is geographically available to them. So we're thinking rural areas where these PCPs are living and their patients. However, nearly half of these PCPs in this study felt they lacked adequate emergency services. And one even noted that the mountainous terrain in their area would make transport out of the community to reach an emergency department for a suicidal patient very difficult. All of the PCPs also stated that if they had access to emergency services, they all noted a lack of personal relationship with psychiatric providers, and that made coordinated care difficult. The PCPs were uncomfortable managing the depression on their own if a patient's depression proved to be treatment resistant or complicated by perhaps a bipolar diagnosis or psychosis. So these PCPs were reporting it was difficult to maintain relationships with psychiatric providers, emergency services, and overall they had several barriers to address to make sure that their patient became suicidal, they'd be able to take care of them. So primary care providers, like we talked about, can bridge this gap, but there are some barriers that these PCPs are encountering in doing so. One way we can talk about primary care providers' role for managing older adults' mental health concerns is through mental health screening. And this can be for depression and anxiety type of screening. And in the study that we talked about earlier, the PCPs often describe chronic pain as constantly present in their older patients, and all describe chronic pain and depression as interacting with each other in a vicious cycle. So the chronic pain piece is also important because PCPs perceive it has a relationship to depression. And some PCPs may overestimate their consistency in mental health screening in that previous study that we talked about. So having mental health screening training could be useful for these PCPs when they're working with their older adult patients. Furthermore, these PCPs may not even be trained in geriatric medicine or in mental health interventions tailored to older adults. Therefore, there's a lot of pieces here to consider what PCPs can do to support their older adult patients, but still there's some areas that they need assistance in. And then we can think about older adults and stigma. And it's more likely that older adults will feel less stigma discussing mental health needs with their primary care provider. About 87% of these older adults aged 50 to 80 feel comfortable talking about their mental health, but only 19% discussed a mental health concern with their primary care provider, and only 10% met with a mental health professional. Therefore, this stigma piece can affect who are they reaching out to for mental health care. Older adults commonly reported depression, anxiety, and trouble with sleep during the COVID-19 pandemic. And this is older adults overall. Since March 2020, nearly 1 in 5 adults aged 50 to 80 reported worse sleep than compared to before the COVID-19 pandemic. 2 in 3 said they had regularly trouble falling asleep or staying asleep 1 or more nights in the past week. Additionally, 1 in 5 of these older adults reported experiencing worse depression or sadness. And about 28% of these participants reported worse anxiety or worry since the start of the pandemic. So overall, older adults' mental health have been greatly affected by the pandemic, like everyone else. Older adults did report engaging in a variety of strategies to improve their mental health, which we talked about with about 1 in 8 said they met with their primary care provider and talked about their mental health concerns. Therefore, it's really important to be thinking about how stigma can affect this relationship that older adults have with their PCPs. They may feel more comfortable, like this 19%, talking to their PCP than meeting with a mental health care professional that they may not know very well. So talking about reducing stigma, one way we can reduce stigma is promote dignity of an older adult. And dignity is the concept of individual respect. With a steady increase in population aging that we have been seeing, the proportion of older adults living with mental illness is on the rise. And this will have an impact on their autonomy, their rights, quality of life, functionality. The biomedical approach to mental health care has undergone a paradigm shift over the recent years to become more inclusive and rights-based, which is one way you can see it with our 4Ms framework and utilizing what matters to older adults and seeing what did they want in terms of their mental health care, their physical health care, whatever type of care they're seeing. So here, when we're talking about the social stigma and discrimination older adults may experience, they may be more likely to talk to their PCPs where they already feel like they have dignity in the relationship with their PCP, and they may be more willing to talk about their mental health concerns. Incorporating this piece of dignity into mental health care for mental health professionals will advocate for more social health policies that can help older adults feel more included in the overall landscape of mental health care. So overall, we can think about the stigma, dignity, and PCPs. And this quote here is, by acting on social determinants of health, it is possible to contribute to promote the older adult's dignity and a better subjective mental health and well-being of older people, to build the capacity of communities to manage adversity, and to reduce the burden and consequences of mental health problems. So through working with Dignity to reduce stigma, this might actually help with the mental health care access in itself, but also improve mental health care services for older adults. And now that we have talked about the role PCPs can play for older adults when accessing mental health care, becoming aware of mental health care, and becoming aware of their mental health concerns, we can think about transitioning to a more integrated healthcare system with an emphasis on dignity for older adults and an emphasis on the importance of the decisions that they are making in their care. Integrated healthcare we'll be talking about more in the next slide, but I first want to also bring attention to how PCP education can improve implementing behavioral health through training, licensing, using technology, and lowering the cost or adding insurance coverage. This can help PCPs become more helpful for their older adult patients. This can help PCPs be more proactive in learning about if their older adult patient comes to them with some mental health concern. So we can add that empowerment piece of older adults and to PCPs who may have reported they don't feel supported in the community or don't feel connected to, say, emergency services, psychiatric services, things like that, that they can help each other and develop more accessible services for older adults. And then we'll briefly talk about medication for older adults in the 4Ms framework and how that can tie into mental health care. So for integrated health care, this is vital for expanding access to behavioral health services. Of course, in rural areas in particular, there's widespread barriers to accessing mental health care, which includes mental health care provider shortages, higher cost, gaps in insurance coverage, and many people, including those rural older adults, they seek behavioral health treatment from their primary care providers. And of course, like we talked about, some PCPs may feel unprepared or not equipped to handle these types of issues. Therefore, we can have integrated health care to equip PCPs and their associated providers with effective tools for diagnosis and treatment, while also expanding the workforce to include paraprofessionals such as community health workers or peer support specialists who can offer counseling, care management, social support, and skill building services. And this approach has been shown to improve behavioral health access and outcomes across age groups and diagnoses. So this would be very helpful for rural older adults who go to their primary care providers and are looking for help with their mental health care concerns. This also in turn will help the primary care providers become more connected to the behavioral health services, mental health services, and that in turn can help the older adults because they feel they have the trust with their primary care provider. And if their primary care provider is helping them find these resources, it can improve the relationship and in turn also help their mental health in the long term. And here's another way of looking at integrated health care with the person in the center. And the person we'll be talking about, of course, is an older adult living in a rural area. And they have their family and informal support. And then you have the primary care as their primary main source of contact to the community. And this primary care provider can help them access specialists, hospital services, even long-term care if needed, home and community services, and public health services. And then, of course, we'll have the community resources and social services overall. And this primary care provider can help be a point of contact for this older adult who has mental health concerns to find someone who can help them in more specific ways than their primary care provider may be able to. And in the 4Ms that we talked about earlier, we can tie medication to this because primary care providers may be a way for older adults to access mental health medications if needed. Maybe they're not writing the actual prescriptions, but they can help find someone who can help them access these mental health medications if they're needed. We could also include having mail order for a medication for an older adult who lives in a rural area. They may not have access to transportation, may not have access to get to the medication. So these are just two ways we can think about the way medication can assist older adults with mental health care concerns as well, and how PCPs can help with that. And thank you everyone for staying listening to this lecture. In lecture 3, we'll be talking about mentation, which is a part of the 4Ms, and we'll delve even more into what does mental health look like for an older adult living in a rural area, but also in terms of how their social networks, social isolation, and belonging can affect mentation or their mental health. So thank you to everyone for coming and listening today, and I look forward to seeing you in the next lecture.